we're still learning how to make our talks engaging virtually.
Well, I hope you teach us all about that today. So we can go ahead and get started. Welcome, everyone. If any of you, I'll keep my camera on so that there's a face for you to see if on your screen, but if anyone else wants to put their camera on for any portion of this, that's certainly welcome, but we understand folks are in places with internet and logistic reasons they can't put their camera on, so that's fine. But welcome everyone to Geriatric Medicine Grand Rounds. We're glad you're all here. It's December. Can anyone believe that? But we have a really fantastic speaker today. I'm very appreciative that Dr. Jenna Thomason has come to speak with us. She is an acting assistant professor in the Division of Rheumatology, and many of you probably know her. She also did her internal medicine residency here at the University of Washington that she finished in 2015, and then did her rheumatology fellowship at the University of Washington that she finished in 2017. She currently practices at the Harborview Rheumatology Clinic. So for those of us in senior care clinic at Harborview, you have seen so many of our patients, and we're very appreciative. And I really appreciate you coming to speak with us today about bugs, blood, and crystals, what is going on with those joints. So thank you so much for coming to speak with us.
Thank you for having me. And I love giving this lecture. It's really fun to give. So thank you for giving me an opportunity. So we're going to talk about bugs, blood, and crystals. And I did over the years have borrowed slides from many of my colleagues who are also very enthusiastic about this topic. I have no disclosure. So the objectives for this lecture are to name 3 causes of an acutely inflamed joint, describe the initial workup for acute monoarthritis, describe the acute management of crystalline arthropathies, including gout or calcium pyrophosphate deposition disease, and understand the acute and chronic management of gout. And I'll say the majority of this talk really is about gout because that is the most common acute inflammatory monoarthritis. So what does BBC joint even mean? Now you've heard of BBC News. We're going to talk about the BBC joint. And what that is an acronym to help you remember the causes of acute inflammatory monoarthritis. B stands for bugs, and by bugs we mean septic arthritis, and that's generally bacterial infection. And blood is hemarthrosis, and then crystals include gout and CPPD. Of course, there are some more rare crystalline arthropathies, but by far the most common are gout and CPPD. And what a BBC joint is a joint that is so swollen and painful that the patient does not want you to even touch it or move it. That's a BBC joint. So we're going to start with a case. So you're seeing a 68-year-old Chinese gentleman with a 15-year history of osteoarthritis. He's being evaluated for severe pain and swelling of the right knee for 24 hours. Very acute. He reports pain and swelling of his left big toe last month, which ultimately resolved maybe after a week or 2 without any intervention. You note that his past medical history includes high blood pressure, diabetes, uses alcohol heavily. He's also obese, and he's got some chronic kidney disease. He's on lisinopril, insulin, and low-dose aspirin. On exam, his temperature is 37.8. He's unable to bear weight on the right leg because of pain. Then he is swollen and warm with overlying erythema, and the range of motion of the joint is limited. And trying any movement elicits pain. You look all over his body, at his penna, his hands, his elbows, everywhere, and you don't see any tophi. So what do you do next? Personally, I would get an X-ray first to see what's going on there. Can we see any acute fracture? Does he have underlying osteoarthritis, which we knew that he did. And here you can see that he does have underlying osteoarthritis, particularly severe in this medial compartment. He's got a lot of subchondral sclerosis here. I don't see any calcium to indicate that there is a chondrocalcinosis in this knee joint, just regular old osteoarthritis. I don't see, fracture or lipohemarthrosis that would make us suspect that he has had underlying trauma to contribute to his BBC joint. You also want to get some laboratory studies, look at his CBC. It'd be important to know what his glucose is. He's a diabetic. If we're considering steroids, and then also his creatinine. We'd like to know that he has CKD, and even if he didn't, we'd want to know that before we give him any systemic therapy. And also you find that his uric acid is quite elevated. It's 10.7 milligrams per deciliter. Then what we'd like to do is get fluid out of that joint so that we can send it down to the lab and have them tell us how many cells are in that fluid. And also, in addition to changing the cell count and differential, also like to get a gram stain and a culture and have them look for crystals. So they did look for crystals. And what they saw were these needle-shaped, negatively birefringent crystals. And importantly, when you see this under the microscope, you also want those to be intracellular crystals. Very, very rarely, the lab might report that there are crystals and perhaps the cell count is not what you would expect for an inflammatory cell count. If the neutrophils are not attacking those crystals, then gout is not the cause of the swollen joint. Does that make sense? So you want to see intracellular negatively birefringent crystals. And they can be out of the cells too, but you just need to see some in the cells. So at this point, you've got a 68-year-old gentleman. He's got a lot of comorbidities. He's got high blood pressure, diabetes, and an acutely inflamed joint with a 24,000 cell count and negatively birefringent intracellular crystals. So he's got gout. And he also had that history of inflammation of his big toe recently. So this has maybe been brewing for a bit. So at this point, what's the most appropriate treatment for this patient? Is it to start him on allopurinol, to give him colchicine? Do you want to start vancomycin? Are you don't want to you're so worried about infection? Do you want to give him a steroid injection into the knee or oral prednisone? Anyone have any thoughts about that? So for me, oh, I see someone in the chat. I like it. I like it. That would be my choice too. So, I mean, you could start him on allopurinol, but you'd want to treat his flare for sure. If you were adequately treating his flare, we used to say in the past, you need to wait 2 weeks after a flare before you start allopurinol. The truth is that if you are controlling the inflammation, you can start allopurinol before that, if someone qualifies for allopurinol. Colchicine would not be effective in this case because colchicine is really better as an abortive medicine. So if colchicine is not started within 24 hours of the onset of the flare, it is very unlikely to work. Vancomycin, I think the infection is less likely in this situation, but say that cell count had been really high, say it was 94,000, then even if the gram stain was negative, we might still feel concerned that there was underlying infection in addition to a gout flare, which does happen. But I think we're feeling pretty comfortable that this is gout rather than infection. Intra-articular triamcinolone is very nice in this situation because it is targeted therapy towards his acutely inflamed joint. It will raise his blood sugar, but not as much as oral prednisone. It's the triamcinolone that we put in the joint. It's a depot formulation. So that's why that has that white chalky appearance, because that keeps most of the steroid in the joint. So this is one of my favorite charts as a rheumatologist, and I have expanded one of these, or I've added many other things, but this is a figure about sorting out synovitis in time and space. And in this lecture, we're really focused on this group here, which is acute monoarthritis. But thinking about how joint inflammation occurs over time and how many joints are affected really does help us figure out what condition the patient is suffering from. So here we're really focused on the BBC joint, this acute monoarthritis related to bugs, blood, or crystals. And we'll go through each of these things. So again, here's our BBC joint. You can see here that the patient is holding the joint slightly flexed. I mean, it's very obviously swollen, but just looking at it, but you can also see the patient is holding it in slight flexion compared to the other knee. That's to allow for the joint capsule to expand as much as possible. We say about 30 degrees flexion is when the joint capsule is expanded the most. And so that's probably the most comfortable position for the patient. You can see that this patient has overlying erythema. And we always say that the erythema in gout is not well circumscribed. So as opposed to somebody that might have bacterial cellulitis, say in their foot or on the knee, those patients, you can take your skin marking pen and make a nice little outline. And we often do that in the hospital to see if it's expanding. But in somebody that has gout, you can imagine trying to take a pen and find the edge here. It's quite difficult. So it's called gouty pseudocellulitis. It's not well circumscribed erythema. And it can be bilateral sometimes if the patient has multiple joints affected or over bursa, bursae. And as I said before, ideally you want to take fluid out of that joint, because number one, we want to know how high that cell count is. Should we be worried about infection? And then number two, we like to confirm we call it crystal confirmation. We like to see those uric acid crystals to know that we're treating the right thing. And we'll talk about, there's sometimes in some situations you might diagnose gout by history or perhaps by ultrasound exam, but crystal confirmation is as good as it gets. And again, you want to see intracellular uric acid crystals. So these figures are looking at examining synovial fluid. So over here in panel A, this is normal synovial fluid. And when you pull this out of the joint, right away, you know that this is normal because you can see the lines here on the other side. When the fluid is inflammatory, you cannot see through it. You cannot see the other side because there are so many cells in this fluid. And then over here, this is just frank pus. This is from a septic joint. The cell count does help us quite a bit, and it's not a perfect test. Again, that normal fluid, non-inflammatory fluid is transparent, and there will be less than 2,000 white blood cells in that fluid. Most of the time, if it's an osteoarthritic joint, we're talking about less than 1,000 cells, but it could be perhaps up to 2,000. Inflammatory fluid, you cannot see the markings on the other side of the syringe. It's usually less inflammatory than a septic joint. The cell count can be usually up to 75,000. There are some cases of gout and other things where the cell count is higher than 75,000. but typically it's going to be less than 75,000. And often septic joints, the cell count is greater than 75,000, but not always. It's kind of a general rule, but certainly not a perfect one. So who gets septic arthritis? Turns out a lot of your patients can get septic arthritis. So often it's kids or elderly people. And your patients have a lot of these other risk factors on this list. So diabetes, patients that have had recent joint surgery or have a prosthetic joint. Also, patients with rheumatoid arthritis are at higher risk, primarily because they have a lot of abnormal joints and may be on immunosuppression that may increase their risk, or have had an intra-articular steroid injection, which thankfully this is very rare. Also, patients with substance use disorders, whether that's IV drug use or alcoholism, are at increased risk for septic arthritis. And then patients with overlying skin infection can be at risk as well. And as well, I think I'll review in the next slide, typically septic joints happen due to hematogenous spread. Direct inoculation from an overlying infection is much less common. Most of these people are getting septic arthritis from hematogenous spread. And it can be a presenting sign of infective arthritis. And again, these patients have a BBC joint, so they have joint swelling, warmth, pain, very restricted movement with a bacterial infection. And all four of these signs are present in 80% of patients with bacterial septic arthritis. Fever is often present as well, but older patients may not be febrile. So you can still consider this if you have a high suspicion. Typically, septic arthritis occurs in large weight-bearing joints. Small joints are very rarely affected, and it's rarely polyarticular. If it's polyarticular, typically associated with rheumatoid arthritis and also has a higher mortality. So in terms of the bugs that cause septic arthritis, it's typically staph, greater than strep, which is greater than gram-negatives, and it's treated with antibiotics and also an orthopedics consult right away. So if you're seeing a patient and you suspect that this is septic arthritis and not gout, it's best to call orthopedics right away to activate their whole system to figure out, is this infection? Does this patient need to be washed out? So again, this is a chart that I recreated from up to date. So staph can occur in healthy patients or those with skin breakdown, damaged joints, or prosthetic joints. Also, we have strep on this list. Gonorrhea, we'll talk about on the next slide. This is something that we have not seen in years at this point, and we'll talk about that. These top three are typically the ones that cause that more BBC joint, that acutely inflamed, painful, difficult to move joint. The rest of the things on this list may be more slow growing and happen in patients that are perhaps immunosuppressed. You may have had patients that have asked you about Lyme disease or Lyme arthritis. The way that this typically presents is with a swollen knee that's not particularly painful, interestingly. So it may be quite swollen, but it's not typically very painful. It's not a BBC joint. So gonococcal arthritis, as I said, we haven't seen this very much in a few years. And in talking with the infectious disease docs, they think that perhaps the strains of gonococcal disease that cause this have been displaced in the community by other strains, but perhaps it will come back in a few years. So this chart is comparing patients with gonococcal arthritis to non-gonococcal septic arthritis. So typically gonococcal arthritis is in young, healthy adults, whereas, as we talked about before, non-gonococcal septic arthritis is in kids or elderly perhaps immunocompromised patients for some of those more slow growing bugs or rare bugs. Gonococcal arthritis is typically migratory, and it can affect, can cause a tenosynovitis as well as arthritis. And also it's associated with these specific skin lesions that are often hard to see. They can be quite small, but they're quite tender. They're vesicle pustules that you probably would see on the extremities, on the hands, and feet. And also, this is very difficult to isolate in the lab. And so if you ever suspect this in one of your patients, we suggest swabbing every orifice to look for this bug. And back to our patient, what if when we pulled that fluid out, what we actually got was blood? So blood or hemarthrosis can occur in a joint due to trauma, hemophilia, and other bleeding disorders. If you probably have a lot of patients on anticoagulation, and so often even just minimal trauma can result in a hemarthrosis. And also patients with osteoarthritis, if they have a degenerative tear of the meniscus, can sometimes get a hemarthrosis. Rarely this is associated with tumors, and that is very, very rare. So back to that initial workup, recall it included x-ray, lab work, and synovial fluid analysis. I always tell our fellows we need an x-ray of these joints, and that is because I have before aspirated a knee thinking that the patient had gout when he actually had a hemarthrosis. And then later on, after we aspirated the joint, we did get imaging, and this patient had a fracture. So this is a patient here that has a fracture of the tibia here, and there's actually another fracture line here. And this is a lipohemarthrosis, which can actually be seen on an x-ray. Of course, if you get a CT, you get a better look at it. And what this is the fat fluid level with low density fat containing suppurnative and blood layering posteriorly. So this is also a fat fluid level that is seen on the x-ray and then better seen on the CT. So what if, instead of seeing those negatively birefringent needle-shaped crystals, we had seen this? Would we have done anything differently? Recall that we gave our patient intra-articular steroid injection, and the answer is no. So what these are CPBD crystals. They're positively birefringent rhomboid-shaped crystals. And the acute treatment of calcium pyrophosphate deposition disease is the same as gout. So calcium pyrophosphate deposits on articular surfaces, and this is common in patients that are older than 55. And so we really don't see this disease in young people, whereas occasionally we'll see gout in a young person, perhaps if they have a genetic mutation, or maybe they have kidney disease. This is a disease that is exclusively seen in sort of middle-aged to older adults. And when you see that chondrocalcinosis on an x-ray, it doesn't always mean that the patient has CPBD. They may have asymptomatic chondrocalcinosis. They may just have calcium in that joint. But the finding of calcium in that joint is associated with having this condition. And CPBD actually comes in two flavors. So these patients can have these acute inflammatory monoarthritis presentations, often affecting the knee or the wrist. Or there are patients that have chronic inflammation from CPBD. And we call that pseudo-rheumatoid arthritis because it does follow a pattern that is similar to rheumatoid arthritis. Typically affects the wrist and the MCPs and the knee often. And the inflammation is sort of this kind of slow, smoldering inflammation. You might feel the patient's knee and feel that it's warm, but it's more of a chronic smoldering inflammation. So this is the patient that has that calcium layering on their X-ray on both sides, in addition to osteoarthritis. And then this is a very common place to see calcium in the wrist here, in the TFCC. And then this patient clearly has a lot of damage in their wrist. So there are a number of endocrine and metabolic disorders associated with calcium pyrophosphate deposition disease, or it can be idiopathic. Again, you can have acute flares like gout flares, and treat them like gout flares. Usually prophylaxis is not needed. Prophylaxis is something we're going to talk about a lot for patients with gout. But in patients that do have that more chronic flavor of their CPPD with chronic low-level inflammation, colchicine is very effective. So on to gout. So gout is triggered, as you all know, triggered by monosodium urate crystals, those negatively birefringent needle-shaped crystals in joints, bursae, and tendon sheaths. And what happens is we have this uric acid circulating in our bodies, and it crystallizes when the concentration is greater than 6.8 milligrams per deciliter at 37 degrees Celsius. So this is an important number. When you're testing your patient's serum uric acid level, it's important to remember this, because they may have some crystallization if their uric acid level is greater than that. So gout epidemiology, none of you are surprised, there's a rising prevalence in the US and other Western countries. And that has a lot to do with the increasing prevalence of comorbidities that promote hyperuricemia. So obesity, hypertension, chronic kidney disease, all of those things. As the prevalence of those things increases, so will the prevalence of gout. And also, with the rising prevalence, we have seen increase in hospitalizations and ER visits for this condition. This is, as you all know, primarily a disease of men, but also can be seen in women. And this is an important point that I think a lot of people don't know. It's a disease of postmenopausal women, and that's because estrogen is protective against gout. And so this is not something that happens in young women. It's a disease of postmenopausal women and men, typically older women, usually with these comorbidities, or a genetic predisposition. We see a lot of gout in Pacific Islanders, particularly Filipino patients. Yeah. So when you're making a diagnosis of gout, you want to exclude mimics, ideally demonstrate intracellular uric acid crystals. But say you're seeing a patient in clinic and they say, I don't have this, an inflamed joint right now, but I did. I had, my big toe was painful and swollen. I couldn't walk. It hurt to pull a sheet up over it, but I didn't do anything. And then it went away in a week or two. That is very suspicious for gout. Usually the presentation is monoarticular. There's a small percentage of patients that can have their first presentation be polyarticular, but far and away, the first presentation is usually monoarticular, usually in the lower extremity. So first MTP is most classic. If the patient doesn't have the first MTP as their first flare, 90% of the patients will eventually have first MTP involvement. So that's very helpful for figuring out by clinical history if a patient has gout. we teach our fellows the differential of acute inflammatory arthritis. So the first MTP is number 1, gout, number 2, gout, number 3, gout. CPPD is extremely rare for it to affect the first MTP. Yes, Dr. McCormick.
Hey, Jenna, does it
Hey.
give us the wisdom about if gout always comes back at the same joint?
It could, not always. I'd say that's yeah, I think that happens, but not always.
Grant told me that that's the lore, is it's pretty dependable that it
Pretty
comes back.
dependable. Yeah, I mean, I guess if patients tend to have the patient I've seen, like if they tend to have ankle involvement, that's very common. But if it's not well controlled, then they usually end up getting it on the other side and then in other joints. But yeah, it loves the first MTP, it loves the ankle, it loves the midfoot. So it is definitely dependable in that way for sure.
Maybe you don't have to re-tap people if it comes back in the same joint.
Yeah, I don't think so.
Okay.
Unless you suspect that they have, septic arthritis or something else. Often it causes a bursitis, alcanum bursitis in the elbow or in the knee, tendonitis. These patients have hyperuricemia, and we always caution that when you check uric acid during acute flares, that serum level will be falsely low. And you can imagine that if a patient is having an acute flare and they have all this crystallization in their knee, when you're measuring their serum uric acid, you're just measuring, what's left over, what's floating around in the serum, when all of that uric acid is in the knee, sort of wreaking havoc in that joint. So typically, when you check a uric acid during an acute flare, that number is going to be falsely decreased by perhaps 1 to 2 points. So we still check it because sometimes even during a flare, uric acid can be 10, or, it could be very low. And then you're kind of thinking, maybe this is not gout. But if I suspected that this was gout and I checked this and it was 6, it wouldn't convince me that this was not gout, because that patient's uric acid is probably 8 or something closer to that. And then also imaging is very helpful, and we'll go through imaging. Gout has a specific appearance on x-rays. So again, acute gouty arthritis. This is a homunculus with the most common areas of involvement represented by larger circles. Again, first MTP is the most common. Patients present with acute, intense pain, erythema, and swelling that develops rapidly. So we say it develops rapidly, escalates to the highest point within 24 hours. That would be the most common history. It's not perfect in every situation, but that is the most common scenario. And again, loves the first MTP, loves the midfoot, loves the ankle. Also can be seen in the knees frequently, the wrist, the elbow, and then sometimes the smaller joints of the hand as well. So gout, there are actually stages of gout. So these patients, they have asymptomatic hyperuricemia for years. And then they develop acute gouty arthritis. And again, this onset initially is typically a monoarthritis. And say it doesn't get treated, the patient gets better in a couple weeks. And then there's this intercritical period until, bam, again, they suffer another acute gouty arthritis. And this situation can go on and on for years before a patient develops chronic gouty arthritis or tophaceous gout. So these patients that you see that have tophi, like this is something that has been ongoing for years and years for them to develop that much urate burden in their life. So you see this triangle sort of grows, becomes wider at the base over the years as as the gout is untreated, as the uric acid level is untreated. So once these people go on to have chronic gouty arthritis, as opposed to that, those patients who are just having acute intermittent flares, they start to have this kind of low grade posi to polyarticular inflammation that is something that they deal with chronically every day, some level of inflammation that is still punctuated by these acute inflammatory attacks. And as opposed to being monoarticular, as it was when they first developed gout, it becomes polyarticular. So they might present with first MTB, midfoot, ankle, and knee, or perhaps even other joints affected because they just have such a high urate burden, and they accumulate tophi over time. So tophi, we look everywhere for them. They can be seen on the ear, very common on the hands and on the elbow. Sometimes you just feel kind of this like thickened substance in the olecranon bursa that can be a tophus. This is a patient with tophi all over the foot. This is a patient that Dr. Starkeybaum saw. I'm sure most of you know about the UW's partnership with Naivasha, the Naivasha District Hospital in Naivasha, Kenya, or maybe have even been there. But Dr. Starkeybaum went and saw some rheum patients a few years ago, and this was a patient that he saw there. This is a patient of mine who has a spinal tophus. She apparently had gout for years, untreated, was admitted to the hospital with acute nerve compression. You can see here there's a tophus sort of impinging on her canal here, and I think these are better seen on the previous slide. And so she was admitted to the hospital with acute nerve compression. They scanned her and they thought that this had to be cancer. And so she had a big workup and ultimately a biopsy. And what this actually was gout in her spine. And she improved. She's doing much better now. Oops. This is an ocular tophus. Never seen that. Can't say I've seen that. So x-rays can be really helpful if you suspect gout, but you're not seeing an acute flare. Getting an x-ray to figure out what's the landscape of their joints, that can be really helpful because gout has a specific appearance. So these erosions are classic for gout. We call them rat bite erosions. They're like big chunks that are taken out of the joint, and they're periarticular. They're not in the joint line. They are periarticular rat bite erosions with overhanging edges. And also in this patient, you can see these areas of sort of hyper density around their joints. These are actually tophi, which it can sometimes be visible on an x-ray, certainly not always, but in this particular patient, this is another clue, although I suspect they already knew this patient had gout. Joint space narrowing due to gout is something that happens very late in disease. It's not something that happens early, like something like, say, rheumatoid arthritis, where the patients, while they're suffering their inflammation, are also suffering joint space narrowing. That's something that happens very late in this condition. Also, in addition to x-rays, ultrasound can be very helpful for diagnosing gout. I have seen patients who were referred to me down the line when they're not having an acute flare, and we're maybe considering gout and other things. Looking for this is called a double contour sign. What this is layering of uric acid in the joint. It's a hyperechoic line. This is the joint surface here. This is the MCP, metacarpal head. And then this is urate icing. And this is just layering of uric acid, and it goes all the way into the joint. You have to be a little bit careful because if someone has fluid in the joint, sometimes you can have something called a fluid interface sign that goes partially into the joint, maybe would stop here, but a double contour sign extends all the way into the joint. And there have been some somewhat recent studies trying to figure out how sensitive and specific is this finding. And we think sensitivity ranges somewhere between 60 to 83%, and specificity somewhere between 76 to 91. So fairly good test, not perfect, but certainly in combination with all of these clinical clues. If you didn't have uric acid confirmation on synovial fluid testing, if you had a double contour sign and a suggestive history, that seems very suggestive that this would be gout. Ultrasound can also sometimes identify tophi as well. Also, this is something called a dual energy CT. This is very cool, and we do these at Harborview. What this is, so this is an X-ray image of a patient with gout, and all of this is tophus, as we saw on the previous X-ray, that sort of cloudy appearance of a tophus on an X-ray. And this is a dual energy CET. So what they do by mechanisms that are beyond me is they use the technology to identify the uric acid, and all the uric acid shows up as green. And this is not always needed because we have all of these other ways of figuring out if someone has gout, but in certain situations, this can be really helpful. So for instance, my patient with the spinal tophus, if there was concern, that she actually had spinal tophi and there was not an area that was amenable to biopsy, she could have had a dual energy CT to identify those lesions in her spine as uric acid. So regarding treatment principles of gout, I tell patients there are several sort of different layers of therapy when it comes to gout. We want to treat your acute attack, and we want to lower the uric acid so that we reduce your risk of future attacks. But importantly, while we are lowering your uric acid, we want to protect you from attacks, because anything that mobilizes uric acid, whether it's drinking a bunch of beer, being on diuretics, or starting and stopping allopurinol, anything that mobilizes uric acid in your body puts you at risk for attacks. So these patients need to be protected while we're getting their uric acid to goal, and we'll talk about that. So for acute attacks, we like to initiate it early, because the sooner you start treating that attack, the easier it is to treat. So NSAIDs can be really effective and easy to have on hand if you have a patient that has normal kidneys and no other contraindication to NSAIDs. Glucocorticoids also effective if taken orally. You can do intramuscular injection or interarticular injection if you have the equipment and the expertise. This is a problem in a lot of your patients who might have diabetes or heart failure, or perhaps they have psychiatric comorbidities, and steroids are not well tolerated, or maybe they have some dementia and they're worried about them being delirious. So also, PO colchicine is effective if used early. So again, remember our first patient, colchicine would not have been effective in that patient because we need to initiate this within 24 hours of onset, because colchicine is a great abortive medicine, not a great medicine if the patient has a full-blown flare. And then also, we use a lot of IL-1 blockade, anakinra in the hospital. We'll talk about that. And very importantly, if the patient that you're seeing with this acute gout flare is already on uric acid lowering therapy, it should be continued. Do not stop the uric acid lowering therapy, continue the uric acid lowering therapy, because again, starting allopurinol will put that patient at risk for flares. And so many times patients will say, like, this medicine made me worse, I'm not taking it. And then that's a problem. So colchicine, it's I describe it to patients as an anti-inflammatory medicine. It inhibits microtubule polymerization, preventing neutrophil migration. The dosing can be tricky in your patients that are taking statins. Maybe they're on carvedilol, maybe they have CKD. The dosing can be quite tricky. And I always work, we have this fantastic pharmacist that we share with senior care, Carol Crawford, who is incredible at dosing colchicine. And it can frequently be used when people have these medications or comorbidity. It just needs to be dosed appropriately. And we even use it in patients on hemodialysis, often use it half a tablet twice a week. And then here is the dosing for acute flare management. We tell them to take 2 and then take 1 an hour later, and then take it twice a day until the flare resolves. In the past, before my time, I think docs told patients to take it until they have diarrhea. We don't typically do that anymore. And then we also have IL-1 medications with IL-1 blockade, typically anakinra. So when patients have a gout flare, the primary mediator of inflammation is interleukin-1. Yes, Dr. McCormick?
Jenny, you didn't mention the bars with colchicine. I've had a lot of people get pretty nauseated with it, and then it's kind of hard to back off once they're nauseated. Any comments about managing that?
Is that with chronic colchicine or with
It's with the flare. I
with
had
the
one
flare.
patient who had pretty significant renal impairment, and once it's in there, you can't get rid of it very
Yeah.
well, so.
Yeah, maybe not for a few days, especially in somebody with renal insufficiency. So yeah, it's tough. I mean, in that patient, you might need to use another therapy. And actually, anakinra can be really good in patients who have contraindications to these other medicines. So say you have somebody that has heart failure or bad CKD, or they can't tolerate colchicine. Anakinra is quite remarkable, and it's very targeted. So this is one of the sort of this inflammatory process is driven by IL-1, and this medication blocks that directly. So all of these medicines, anakinra, rilonacept, canakinumab, this one, I'm not going to try to pronounce. I've never used this, but these medications are all IL-1 blockers, and they're very effective for gout. But if you trained at other institutions, you may have never heard of using these for gout. And that's because this is not yet FDA approved, and we have not had specific studies that were looking at this question until now. This is the first RCT with anakinra for gout. And it was just published a few months ago, so August 2021. So we're pretty excited about this because this medication is incredibly helpful and useful in these patients that have contraindications to these other medicines.
You want to mention the cost stuff, Jenna? How about the pocketbook?
Yeah, so that's a great question. So anakinra probably costs about $100 a shot. And so if the patient is, say, in the hospital and you can use other medicines, then we will use other medicines. But if they have contraindications, then we will reach for anakinra. And if you think back to that slide about how the incidence and prevalence of gout is increasing dramatically, and hospitalizations and ER visits are increasing, if you compare the cost of outpatient anakinra for a patient versus an ER visit, then there's going to be a lot of cost savings there. So this is something that we expect to be used more and more over time. And hopefully, will ultimately be cost savings associated with it. We have gotten anakinra approved for a few of our patients as to have on hand for acute flares, or even as for gout flare prophylaxis if they have contraindications to other meds for prophylaxis. And I had one patient amazingly on canakinumab. Canakinumab it's a monthly injection. And so this was a young patient with polycystic kidney disease and bad gout tophi, and was just flaring all the time. We got canakinumab approved for him, and he's doing amazingly. He just stopped it. He dissolved his tophi with being on canakinumab and for protection and allopurinol.
That's great, Jenna. That it's $100 isn't so bad. I thought it was going to be in the 4 digits, but
No.
since it's not FDA approved, that's going to come straight out of the wallet.
Yeah. So, and I should say that it's $100 per shot, and usually it's a 3 dose for acute flare, 3 doses. And some of you might say, can you use anakinra in the setting of acute infection? Because it's a biologic that we're talking about. And actually, this is a study that was done by our colleagues a couple of years ago that looked at concurrent anakinra use in the setting of infection. There was no indication of worsening infection when these patients were given anakinra. So it really is a great medicine. So back to our patient quickly. 68-year-old gentleman, 15-year history of osteoarthritis, hypertension, diabetes, heavy alcohol use, obesity, chronic kidney disease, treated with lisinopril, insulin, low-dose aspirin, recently admitted for acute gout flare, comes to see you in clinic. You gave him that interarticular steroid injection a couple of weeks ago. He's doing much better. His creatinine's at baseline. So essentially, what do we want to do for him now? And remember, he had that painful MCP also recently. Really what this question is getting at is, what do you want to start him on chronic uric acid lowering therapy? Do you want to wait and see if he has another flare? And if you do want to start him on uric acid lowering therapy, is there a particular dose that you want to give him? So since we're running low on time, I'll tell you what I would do. So I would do this first, which is check this genetic locus. And what this is this tells us about his risk for hypersensitivity reactions to allopurinol. And generally, we want to wait for this to be back before we start someone on allopurinol. So indications for uric acid lowering therapy, patients that have tophi, radiographic damage, or 2 or more attacks per year, uric acid lowering therapy is strongly recommended for those patients. But there are also, and this is per the ACR guidelines that were just released in 2020, they also conditionally recommend using uric acid lowering therapy in patients with CKD 3 or worse, uric acid that is very high, or a history of uric acid stones in their kidneys. And they recommend against treating asymptomatic hyperuricemia. And that's because we have not been able to demonstrate benefits of treating asymptomatic hyperuricemia. First line therapy for uric acid lowering are the xanthine oxidase inhibitors. Allopurinol, our old friend, it's been around for a long time and it is effective. The primary reason why allopurinol fails is because people don't take it. It's a daily medicine, and sometimes people have to take multiple pills, and so it can be hard to take, but that is the primary reason why it does not work. Febuxostat is a newer drug, and it's far more expensive. It's also a xanthine oxidase inhibitor, and it's also effective. And I have a slide. We don't know which one is more effective. There are some reasons to choose one or the other. I'll go to that. And then there are also. Yeah.
Oh, I was going to ask about that, about adjusted dosing for CKD, which is, as you said, one of the indications for uric acid lowering.
Yeah.
Does febuxostat, I have a couple patients Carol's titrating onto that.
Mm-hmm.
I don't know. Sorry if you were going to already go over that.
Yeah. I'll talk about that briefly. I think it's on the next couple of slides. There's also alternatives. So, and these are used less common. Probenecid. It is only effective in patients that have creatinine clearance greater than 50. So it's not used super commonly. This one I've never used. And then there's also pegloticase, which I'll talk about briefly. So allopurinol, it's, as I said, it's an old drug. It's very effective. It started at 100 milligrams daily, but in patients that have creatinine clearance less than 60, then we start with 50 milligrams and we slowly up titrate the dose. That's because the risk of hypersensitivity reactions are tied to the starting dose and the rate of up titration. So in someone that has CKD, we'd start with 50 and we only increase it 50 milligrams at a time. Another reason why people, may have thought that allopurinol was ineffective is that often it's not used at a high enough dose. Perhaps the patient was only given 300 milligrams. That is ineffective for about 50% of patients. So we up titrate the dose to a max of 800 or 900, including in patients with CKD. And there's a lot of good data about safety of using allopurinol in patients with CKD. Febuxostat, there's not a lot of data about using it in patients with CKD. And so this is undefined. At lower creatinine clearance, they recommend no more than 40 milligrams per day. And then beyond this creatinine clearance, it's not defined. And also there's just not a lot of data about using it in patients with liver disease. Also in 2018, there was a study, it's called the CARES study, where they determined that febuxostat was associated with increased cardiovascular risk. And so now when we prescribe febuxostat, we have to warn patients about this US box warning. But it turns out there were a lot of problems with this study. There was a huge dropout rate. There was 50% dropout in both arms. And in fact, the events happened in the patients that actually discontinued febuxostat. So it was sort of confusing. Is febuxostat protective? We don't know. And also another interesting thing was that the events happened in patients that were not on aspirin. The patients that were on aspirin actually did not have events. And also the patients that had events were on NSAIDs, whereas the patients without events were not on NSAIDs. So there were a lot of problems with that study. And this is another study that was just published in 2020. It's called the FAST study. This was done in Europe, where they compared febuxostat and allopurinol to look at adverse cardiovascular events. And what they found was that febuxostat is non-inferior to allopurinol for adverse cardiovascular events. So this was their primary event endpoint, which was all cause. I think it was all cardiovascular events, and then this is specifically all cause death and cardiovascular death. And they found actually no differences. And someone might ask the question, which is more effective, allopurinol or febuxostat? And the answer is that we don't know. Febuxostat was more effective than allopurinol in the phase 3 registration trials, but when they were comparing febuxostat to allopurinol, they only used allopurinol 300 milligrams. And as we talked about, that's an adequate dose for about 50% of patients. We will reach for allopurinol first every time. And that a lot of that has to do with the cost. It's just far less costly. We feel that it's safe, particularly in patients with CKD. And then there's this, there's a lingering question of cardiovascular events, but that box warning, is still on there. But if you need to use febuxostat, then you need to use it. But we always reach for allopurinol first. And I'm running out of time here. Can I go a little bit longer? Is that okay? Or if people need to hop off,
a minute or so to wrap up.
I'm sorry, what'd you say?
Oh, maybe just a minute or so to wrap up.
Okay. So I really want to talk about HLA-B 5801. Actually, let me go back one slide. So very importantly, as we're talking about, the uric acid crystallizes at a concentration of 6.8 milligrams per deciliter. So we really want the uric acid to be below that level. And in fact, if patients have tophi present, then we shoot for even lower when we're on our, when we're using uric acid lowering therapy. I'm going to skip this. This is the treat to target controversy. So the ACP and the ACR would disagree about this concept. And I think honestly, for different patients, either strategy may be appropriate, but the ACP does not recommend targeting a specific level of uric acid. But there's a lot of really good data that if we can get these patients to a specific, to these goals, a uric acid less than 6 for patients without tophi or less than 5 with tophi, we can really, really decrease their probability of flaring. And this is perhaps, in my opinion, the most important slide of this whole presentation. This is about prophylaxis when you're initiating uric acid lowering therapy. So when you see your patient who has gout and you decide that they meet criteria for uric acid lowering therapy, they must be on medication to protect them from flares until their uric acid is at goal. So just to orient you here, these different lines correspond to febuxostat at different doses, and then also allopurinol. This is the percentage of subjects with at least one flare in a 4-week period. And then this is the period over weeks. So you can see that as these patients are initiating any of these uric acid lowering therapies, these patients are flaring like crazy. Over 40% of them are having flares as they're initiating these therapies. And so as we're getting, but when they're on it long-term, they have a reduction of flares because they're lowering their uric acid. So as we're getting patients through this period, we really need to protect them. And what we typically use is low-dose colchicine, which is very effective for protecting patients from flares. So we use a daily or every other day. And sometimes, unfortunately, because of some politics, colchicine can be expensive for some patients. But in patients that have creatinine clearance greater than 50, you can actually use this colchicine probenecid combined pill, which is very cheap. It's it's an older, it's just an old medicine combination pill, and it is very cheap. It's like $16 or less per month, compared to sometimes I've had patients who have paid $300 for a month of colchicine, and I'm like, no, don't do that. There are ways around it. You can use low-dose NSAIDs or low-dose prednisone, and in some patients we've used IL-1 blockade who maybe had contraindications to these other medicines. But the important point is we must protect these patients while we're getting the uric acid level to goal. Otherwise, they will tell you, this medicine doesn't work for me. It makes me worse. So we just have to protect them until we can get their uric acid to a level that is safe for them. Dietary changes, constantly I do it. It's probably, less of an issue than meds, although patients who are heavy alcohol drinkers, this is a big deal in terms of contributing to their uric acid load for sure. I've had patients that had to go on allopurinol just because they drink so much. I have a patient his uric acid is at goal on 100 milligrams of allopurinol, but he drinks 30 hard liquor drinks a month and would rather take a 100 milligram allopurinol pill every day than stop drinking. Also very important is, how can we modify patients' medications in a way to help them lower their uric acid? This is particularly important in patients that are on maybe a lot of medications and maybe have contraindications to some of our gout meds. So if you can switch them from, say, lisinopril to losartan. Losartan actually is uricosuric, and it will actually decrease the patient's uric acid load. Fenofibrate also decreases uric acid, whereas medications like hydrochlorothiazide, if you can switch them off of that, or off of furosemide, you'll actually help them be able to get rid of some uric acid. Pegloticase is just this crazy expensive infusion medication that dissolves tophi like wild, but it's incredibly expensive and very immunogenic, so patients can have acute reactions to it. So in the future, we may see more use, but it's incredibly expensive. Most common mistakes I've seen in gout management are not titrating uric acid lowering therapy to target. So a patient who's on allopurinol 300, but their uric acid is still 7 or 8, that patient needs to be up titrated to target. And they need to be on prophylaxis while they do that to prevent them from flaring. So that's another big one. Also, stopping allopurinol during flares. We still see that happening, or stopping or lowering the dose of allopurinol in patients in the hospital with AKI. We prefer just to continue it, and there's some safety data about that. And then also HLA-B51 801, I mentioned that briefly. That is a genetic allele that is associated with hypersensitivity reactions in allopurinol. And so we recommend checking this in patients who are Chinese, African-American, Korean, and Thai, because they have a high prevalence of this. And then if they have this, then we don't use allopurinol, we use something else. This was a study that was done about stopping and starting allopurinol in our hospital. I include this because this was done in patients at Harborview and UW. And it just showed how stopping or decreasing allopurinol in hospitalization led to significantly more flares within 3 months of discharge. So these are learning objectives, and this is the end. Thank you, guys. Sorry I went over.
Thank you so much.
Yeah, you're welcome.
There was a request for your slides from particularly some of the fellows. If you're willing to share those, we have a recording.
Yeah, sure.
But yeah, thank you so much.
Yeah, thank you, guys. And for UW folks that are on, actually, e-consults is a great, turns out to be, a great tool for complicated gout management. So if you have a patient that has gout and you think like, oh, I don't necessarily want to send this patient to room clinic, or the patient may have trouble getting there, but I think I need some help reviewing what to do for this patient, e-consults are great. Can be great for those patients. And then also we do telemedicine also for patients with established gout that may need just some help with maybe education or going over medications and figuring out how to manage maybe their colchicine dose or various things on all these medications.
Well, thank you again for coming to speak with us. This is really, really helpful.
All right. Thank you, guys.
Thanks.